Zoll Life Vest is a proud sponsor of Cardio Nerds. Zoll has continuously improved Life Vest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest Life Vest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey cardio nerds, this is Rick Ferraro, cardio nerd, imaging fellow at the University of Michigan, and someone who is extremely excited to be in Miami right now for an incredible case from some great fellows at the Mount Sinai Medical Center in Miami, Florida. I am thrilled to be joined today by Dr. Sri Mandava, David Meister, and Marisa Donatelli, who are going to take us through an incredible case. Would you all mind introducing yourself to our audience quickly?
Thank you, Rick. So my name is Sri Mandava. I'm one of the second-year fellows over here at Mount Sinai Medical Center in the wonderful Miami Beach, Florida. I am from California, did my residency over in Santa Barbara, California as well too. I am interested in pursuing a subspecialty in interventional cardiology and structural heart disease, and really looking forward to talking more about this case. Thanks for having us.
David Meister, also a second-year cardiology fellow at the wonderful Mount Sinai Medical Center in Miami Beach. I am from New York originally, did my residency over in New York at Mount Sinai West. I'm interested in advanced cardiac imaging and also thrilled to be here with my co-fellows and cardio nerds.
Hi, I'm Marisa Donatelli. I'm also a second-year fellow at Mount Sinai in Miami Beach. I'm originally from Minnesota, but I did my residency at Mount Sinai in Miami Beach as well. And I'm interested in cardiac critical care. Thanks for having us.
Hey everyone, Dan Amador here, and so excited to be here with Marisa, Sri, David, and Rick. I have my flip-flops on, I smell that ocean salt, and I'm shooing away some seagulls as we go head out to where we are going to be learning about cardiology. So team, why don't you take us to one of your favorite places in Miami Beach so we can settle down and learn something?
Actually, believe it or not, our favorite place is just in our backyard, right on Biscayne Bay, literally in the backyard of the hospital where we can catch some excellent sun, get a view of downtown Miami, and hopefully see a few beautiful boats passing by.
That is spectacular. I'll tell you, coming from Michigan, I'm a little jealous. I think it might be a little bit warmer in your backyard today than in my backyard. But why don't we kick things off and why don't you take us through the case?
Fantastic, thanks. So we have a 57-year-old male with a past medical history of hyperlipidemia who presented with acute onset severe substernal pressure like chest discomfort that awoke him from sleep about 30 minutes before arrival. The pain was left-sided and substernal. It radiated to his left shoulder. The pain persisted for several minutes, which prompted him to present to the emergency room. The night prior, he had returned from a hiking trip in South Carolina, where he was extremely active without limitations. The patient was recently diagnosed with hyperlipidemia, for which he was started on rosuvastatin 20 daily. Apart from surgery on his knee and shoulder in 2013, the patient is fairly healthy without any other significant medical history. He denies any family history of MI, CHF, arrhythmia, premature CAD, or sudden cardiac death. He denies alcohol use, smoking, or drug use. He leads an extremely active lifestyle, regularly engaging in moderate intensity activities for 2 to 3 times a week.
Thank you, Marisa, for sharing the details of the patient presentation. As fellows in cardiology, we get called all the time for patients with chest pain, and the first question we tend to ask ourselves is it acute coronary syndrome or is it something else? But I mean, in this fairly young patient with no significant medical history, apart from hyperlipidemia, it's essential to maintain a broad differential diagnosis. David, given the information provided so far, what would your differential be at this time?
Well, at this point, usually I'd be worrying about a life-threatening condition. Acute coronary syndrome is certainly something at the top of my differential. With more detailed information, I would also consider other life-threatening conditions, such as pulmonary embolism and aortic dissection. That said, I'd like to hear more about the clinical presentation.
Sure, David. In the ED, the patient was normotensive with a blood pressure of 126/95, a heart rate of 58, a respiratory rate of 22, and saturating 100% on room air. His BMI was 26. Of note, his blood pressure was equal on both arms. On exam, he was in mild acute distress and diaphoretic. He had normal heart sounds without any murmur. His cardiopulmonary exam was otherwise unremarkable, however. His extremities were warm without any lower extremity edema. His chest x ray showed a normal cardiac silhouette without evidence of pleural effusion, pulmonary edema, pneumothorax, or a widened mediastinum. Here's the kicker, however. His EKG shows a normal sinus rhythm with a right bundle branch block. He had greater than 1 millimeter ST elevations in the inferior leads and 1 millimeter ST depressions with upright R waves in V1 to V3. A code STEMI was activated and he was emergently brought to the cath lab.
So we have an inferior-posterior STEMI. In this situation, I mean, what's on your mind, David? We would like to hear your thoughts on pre-cath planning.
So at this point, we're likely dealing with an ST elevation acute coronary syndrome. Given the inferior ST elevations, I'm definitely concerned about right ventricular involvement. Was a right-sided EKG obtained?
Funny you should ask, David. It sure was. There was no ST elevations in the right sided leads. What are you anticipating to find in the cath lab?
Well, given the posterior involvement and the noted ST depressions in lead V1, I'm probably suspecting a left circumflex artery as the culprit. So what did the cath show?
So based on the angiogram, it turns out that the patient had a codominant system with a complete thrombotic occlusion at the bifurcation of the mid-left circumflex and the first obtuse marginal branch. So the patient underwent a successful aspiration thrombectomy and percutaneous coronary intervention. And of note, there was no evidence of any other coronary artery disease of the other remaining epicardial vessels.
Interesting. So, I mean, what we have here is a complete thrombotic occlusion in a single vessel, the mid-left circumflex and first obtuse marginal branch, which correlates quite well with what we saw in the EKG. So we do have a STEMI, but what's interesting here is that we have no evidence of atherosclerotic disease elsewhere, which is, relatively unusual. So what happened next?
So the patient was then transferred to the CCU for further management, a kind of post-PCI. And Marissa, as the CCU fellow on call that night, how did the patient progress?
Yeah, Shree. So I saw the patient when they first got to the unit. When they show up to the unit, we're most concerned about their hemodynamic state, their resolution of chest pain from a STEMI, and then any EKG changes. We want to see those normalize. So this patient did arrive to the unit very calm, without chest pain. His immediate post-procedural EKG showed normalizations of all his ST changes. He was hemodynamically stable, not requiring any pressors. At this point, I'd like to assess his biventricular function and any other valvular heart disease. So I would like an echo at this point.
So here are the echo findings. It showed that the left ventricular ejection fraction was 30%, with hypokinesis of the inferior, lateral, and the apical regions. The left ventricular end diastolic pressure was normal by echo. The right ventricle was normal in size, and the systolic function appeared mildly impaired. There was no hemodynamically significant valvular disease by echo. However, there was a laminar massive echoes in the apical left ventricle consistent with the thrombus. David, what about this seems a bit unusual?
Well, first and foremost, I'm somewhat surprised by the absence of atherosclerotic disease here. This does not seem to be a run-of-the-mill STEMI. I'm also surprised by the regional wall motion pattern seen on the echocardiogram.
What makes you say that?
Well, while the left circumflex and obtuse marginal occlusion can explain the lateral and inferior wall motion abnormalities, it does not really account for apical involvement. Typically, the apex is supplied by the left anterior descending artery, unless there is significant left posterior descending artery arising from the left circumflex artery. However, this was a codominant system, making this scenario less likely. Shri, what do you make of this?
Based off of the information we have so far, it's just so unusual to have such a degree of LV systolic dysfunction with the territory that's been involved, the left circumflex, with the ejection fraction being 30%. And from experiences in the past and from what I've read, you can see an apical left ventricular thrombus in like a large LAD infarct or an anterior ST elevation MI, which is not the case here. This further begs the question, what explains the apical wall motion abnormality in this patient?
I totally agree with that. The findings are out of proportion to what you would expect based on the angiogram, right?
Yeah.
Like a circ lesion is not going to give you a 30% EF with an apical thrombus in most circumstances. And so really kind of pointing that out, I think, is helpful.
So at this point, we suspected that the left circumflex thrombotic occlusion resulted from thromboembolism in the setting of an apical left ventricular thrombus. So, we pursued a hypercoagulable workup to evaluate for thrombus, but also then the question is, where did the apical wall motion abnormality came from? So for the hypercoagulable workup, he was COVID-19 negative, protein C and S were within normal range. The antiphospholipid antibodies panel was negative. homocysteine levels were normal, and the anticardiolipin antibody was normal. So given this negative hypercoagulative workup and the further evaluation of the discrepancy in the wall motion abnormality, we decided to obtain a cardiac MRI. David, what were the results of the cardiac MRI?
Thank you, Sharif, for summing that up so well. I think before we jump into the cardiac MRI, why don't we just take a step back and just, run through a few teaching points on LV thrombus. So, Marisa, what should we be thinking about when we see an LV thrombus on an echocardiogram?
Thanks, David. When I think of an LV thrombus, I think of causes such as acute MIs, especially anterior MIs, but heart failure in general or through severely reduced ejection fraction, non-ischemic cardiomyopathies like dilated or HCM, arrhythmias, more ventricular, but AFib as well, can also contribute to left ventricular thrombus in cases of severe LV dysfunction. Hypercoagulable conditions, inflammatory conditions such as myocarditis or cardiac sarcoidosis, which can lead to inflammation and contribute to thrombus formation. This, paired with the concern for non ischemic cardiomyopathy, may have helped us decide what to do next, which is why we thought, let's get an MRI. So, David, what were those results?
So there were really two key findings on the cardiac MRI. First, there was diffuse hypointensity throughout the basal to distal lateral left ventricular wall, which we thought was consistent with ischemic obstruction. As we saw on the cath, there was, that acute thrombotic occlusion of the left circumflex artery. We believe, again, that this correlated with the left circumflex lesion, which was reperfused during the left heart catheterization. Second, and I think most importantly here, there was a large amount of diffuse late-gadolinium enhancement involving the basal to mid-interventricular septum, the anterior and inferior RV insertion points, and the basal to distal inferior wall. The late-gadolinium enhancement really represents fibrotic myocardium, and we felt this pattern was consistent with cardiac sarcoidosis. Moreover, involvement of the anterior and inferior insertion points is a classical pattern of late-gadolinium enhancement seen in cardiac sarcoidosis. This is classically known as the hook sign. Lastly, the findings of biventricular dysfunction seen on the echocardiogram were confirmed on the MRI. Given the lower likelihood of isolated cardiac disease, we proceeded to look for extracardiac involvement of sarcoidosis. We obtained a CT chest, which was notable for calcified mediastinal lymph nodes with associated pulmonary nodules and diffuse bronchial wall thickening. This further raised the suspicion of pulmonary involvement. With all that said, why don't we take a step back and summarize what we have so far?
Thanks, David, for telling us about those MRI results. But to try and summarize, we had a relatively young patient who presented with an ST elevation MI, secondary to an acute thrombotic coronary artery occlusion, with otherwise no evidence of coronary artery atherosclerosis elsewhere. He was found to have a reduced ejection fraction with an associated apical left ventricular thrombus and regional wall motion abnormalities that could not be explained by the culprit vessel alone. So this prompted a more thorough diagnostic workup, including an assessment for hypercoagulable state and causes of non-ischemic cardiomyopathy. Cardiac MRI and CT chest findings raised high suspicion for cardiac sarcoidosis with non-cardiac involvement as well. Although tissue biopsy revealing non-caseating granulomas provides a definitive diagnosis of cardiac sarcoidosis, this was deferred as the patient was receiving uninterrupted triple therapy in the setting of a recent percutaneous coronary intervention and left ventricular thrombus. Given the imaging data and the clinical presentation, there remained a strong suspicion of cardiac and pulmonary sarcoidosis. And due to the patient's severely reduced ejection fraction concerns regarding cardiac sarcoidosis, electrophysiology was consulted to assess the need for primary prevention with an implantable cardioverter defibrillator. But in the absence of a definitive pathology-supported diagnosis and the young age of the patient, the ICD implantation was deferred and the patient was provided with a wearable defibrillator for protection against sudden cardiac death. So the patient was advised to follow up as an outpatient, to optimize guideline-directed medical therapy, and to undergo a PET scan to assess for active inflammation secondary to sarcoidosis and reassess the left ventricular ejection fraction with an echocardiogram. Prior to discharge, pulmonology was also consulted due to the CT findings of the mediastinal and the bilateral hilar lymphadenopathy, suggestive of pulmonary sarcoidosis. The patient was initiated on a steroid taper, and the possibility of a future biopsy for a definitive diagnosis of sarcoidosis was discussed once antiplatelet anticoagulant therapy could be safely held.
Thanks, Shri, for a great summary of this interesting case. All of us need to remember that cardiac sarcoidosis can present with a variety of symptoms, including arrhythmias, heart block, heart failure, sudden cardiac death, or in our case, a thrombotic STEMI. Symptoms can be subtle or mimic other cardiac conditions. Conduction abnormalities, particularly AV blocks or ventricular arrhythmias, are common and may be the initial indication of a cardiac involvement in sarcoidosis.
Ooh, and don't forget about primary prevention of sudden cardiac death and cardiac sarcoidosis, focusing on risk stratification with ICD placement for those high-risk patients. And for patients awaiting definitive diagnosis, a life vest or a wearable defibrillator may be used as a temporary measure to protect from sudden arrhythmic events until an ICD is placed. David, any final thoughts from an imaging standpoint?
Yeah, of course. Well, the combination of echocardiography, FDG PET, and cardiac MR are indispensable in the diagnostic workup of suspected cardiac sarcoidosis. Both cardiac MRI and FDG PET provide a complementary role in the diagnosis. Cardiac MRI is an effective diagnostic screening tool with fairly high sensitivity, but is limited by its inability to decipher inflammatory or active disease, as opposed to fibrotic or scarred disease or burnt out myocardium. FDG PET helps to make this discrimination, refine the diagnosis, and guide clinical management. Ultimately, these studies, as with any other diagnostic tools, are most useful when interpreted within the context of other clinical information.
So, in conclusion, we had a relatively young patient who presented with a STEMI secondary to an acute thrombotic occlusion of his coronary arteries with otherwise no evidence of coronary artery atherosclerosis. Additionally, the patient had LV dysfunction, LV thrombus, and regional wall motion abnormalities that could not be explained by the culprit lesion. This prompted further diagnostic workup, which ultimately led us to the diagnosis of cardiac sarcoidosis.
Amazing. Thank you, guys. Thank you, David and Marissa. I mean, this was unique in that we all cared for this patient together, and it was very educational for all of us.
So this was an incredible discussion. I can't thank you all enough for presenting this case. And I really want to compliment you all on keeping a broad differential and keeping your mind open to possibilities, especially when things don't fit the picture as expected. And so what you all notice is we all know that having a STEMI can cause a reduced EF, it can cause a thrombotic occlusion, it can cause wall motion abnormalities. But what you found on your echo didn't fit the picture of what you saw on your angiogram. And so you pursued additional diagnostics that really helped this patient. You talked a lot about sarcoidosis. I would point some of our listeners to prior episodes that the cardio nerds have done on sarcoidosis. One of my favorites as an imager is the nuclear and multimodality imaging episode, number 134, which is really spectacular and talks a lot more about the diagnosis from an imaging standpoint specifically. But something that's come out since then that I find extremely valuable in my own practice is the AHA scientific statement on the diagnosis and management of cardiac sarcoidosis. This came out in April of 2024, and it has an algorithm that is really spectacular. It really takes you through diagnosis and management as well. But from a diagnostic standpoint, it really walks providers through in a way that is really helpful and frankly highlighted by your case. And so again, I would congratulate you all on providing really good care and appreciate all the teaching you've done today.
Thank you, Rick. We'd like to introduce Dr. Pranav Venkatraman, who is an attending here at Mount Sinai Medical Center. He's an outstanding addition to our program and excelling as a mentor for all fellows and providing invaluable support with research projects.
Thank you, Marissa, David, and Sri, for that excellent discussion on a not so straightforward clinical case with quite an atypical presentation. And thank you so much, Rick and Dan, for having us on the podcast and discuss this case. I feel that this case highlights the truly heterogeneous nature of the sarcoidosis disease process. Although sarcoid is classically associated with pulmonary disease in our minds, not only can it affect almost any organ or combination of organ systems in the body, including the heart, but can also affect the same organ system of each person in a different way. In fact, cardiac involvement is generally thought to occur in about 5% of patients with pulmonary or systemic sarcoidosis, but the true prevalence of cardiac sarcoid is uncertain and is likely underestimated, since many individuals have nonspecific symptoms or subclinical disease. For instance, autopsy and imaging studies have identified cardiac involvement in up to 30% of sarcoidosis patients and in up to 25% of deaths from sarcoidosis. Cardiac sarcoid can also affect patients of all backgrounds and ages, with an average age of 50 years old at presentation. Interestingly, our patient is also around this age range. Most often, the clinical manifestations of cardiac sarcoid tend to be syncope, decompensated heart failure, heart block, ventricular arrhythmias, sudden cardiac arrest, or some combination thereof. However, coronary manifestations, as seen in this patient, are also possible, which can sometimes lead to a rather confounding clinical picture. For example, sarcoidosis can produce coronary vasculitis, which can lead to acute coronary syndromes, and case reports have also described vasculitis-induced spontaneous coronary artery dissection. In our patient who presented with acute MI secondary to a circumflex artery thrombosis, coronary embolization of the LV thrombus was felt to be the cause of the MI. And while I do agree that this is the most likely explanation, I'm not sure if we can fully rule out the possibility of, for example, a de novo thrombosis secondary to coronary vasculitis. And I do feel it should be considered if the patient were to have recurrent MI in the future. Furthermore, cardiac sarcoidosis and atherosclerosis can coexist, which can further muddle the clinical picture. Apart from the diagnostic challenges involved in this case, it's important to discuss the management of the disease process as well. As Sri touched on earlier, the patient was discharged on steroids plus guideline-directed medical therapy for heart failure, and we helped him establish with an advanced heart failure cardiologist. Coming to the issue of appropriateness of ICD implantation, it's worth noting that the patient did not have any ventricular arrhythmias, so this would be a primary prevention ICD indication in his case. He did, however, meet certain criteria that would benefit from primary prevention ICD, such as left ventricular ejection fraction at 35% and extensive multifocal late-gadolinium enhancement on his cardiac MRI. However, since he did not yet have a formal diagnosis of sarcoidosis, and a significant portion of his LGE could not be fully distinguished from having an infarct versus sarcoidosis etiology, the decision was made to defer ICD implantation for the time being, with plans to continue immunosuppressive therapy plus heart failure medical therapy for at least 3 months in order to give his LV function a chance to recover, and then in the future to reassess, perhaps with consideration for an EP study to look for inducible VT. This particular situation I felt was quite eye-opening, as it highlighted the nuanced decision-making involved in assessing risks versus benefits of primary prevention ICD implantation, especially in a not very straightforward case like this one. On the other hand, his outpatient clinical course highlights systems-based challenges and emphasizes the importance of lifelong systems-based practice in patient care. For instance, PET scans can be quite valuable, not only to make the diagnosis of sarcoidosis, but can also help distinguish between areas of active sarcoid inflammation in the myocardium versus burned out myocardial sarcoid scarring. Unfortunately, the patient's insurance would not cover a PET scan, and he could not undergo biopsy at the time due to the need for uninterrupted antiplatelet and anticoagulation therapy. Thankfully, his EF did recover to greater than 35% with prednisone, methotrexate, and heart failure medical therapy, with plans to escalate therapy in the future to mycophenolate or a TNF-alpha antagonist if his disease activity were to recur. His LV thrombus also resolved the anticoagulation, and he did eventually undergo a biopsy a year later, which showed myocardial inflammation, but no evidence of granuloma. Nonetheless, given evidence of pulmonary involvement at the time of diagnosis, his clinical improvement on immunosuppressive plus heart failure therapies, and the limitations of a biopsy in diagnosing sarcoidosis due to skip lesions, his overall clinical picture was indeed deemed consistent with cardiac sarcoidosis. It remains to be seen how he fares in the long term, as prognosis of cardiac sarcoidosis is often variable and dependent on multiple clinical factors. Although he did present with ventricular arrhythmias, his severely reduced left ventricular systolic function with clot formation and an embolic infarct does indeed point to a highly inflammatory and prothrombotic substrate. While there's a tendency to think that prognosis is more favorable in patients who are asymptomatic or don't have arrhythmias, it's extremely important to remember that sudden cardiac death can be the initial manifestation of the disease. I want to thank you all for your time in listening to this challenging case with multifaceted diagnostic and treatment decision-making, including some systems-based challenges. Again, a big thanks to David, Marissa, and Sri for putting together this excellent case summary. And I would also like to thank the CardioNerds team for giving us the opportunity to discuss this case. Thank you.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.